Good afternoon, everyone. Firstly, I thank the scientific committee for having me here. Today, let us talk about dry eye disease with respect to aqueous deficiency and what can we do beyond lubricants to treat such patients. First of all, how frequent is aqueous deficiency dry eye? In our clinic, we see around 20% of patients to have a aqueous deficiency dry eye disease and 40% will have mixed, that means evaporative and aqueous deficiency dry eye disease. In the classification, we see the causes to be Sjogren's syndrome, non-Sjogren's syndrome that include lacrimal disease, obstruction, reflex-related diseases, and of course the autoimmune diseases. Now, the basic evaluation of dry eye that includes all our clinical tests can also include something called a Sitka ocular staining to diagnose these patients, because when the patient presents to us, we need to classify it as aqueous before proceeding with the treatment. Our Schirmer's test is very important. A low Schirmer's is definitive. Even as an ophthalmologist, we need to take some systemic history and examination to check for Sjogren's syndrome, which is pretty common. Secondary Sjogren's we see mostly for rheumatoid arthritis, systemic lupus, scleroderma, and mixed connective tissue disorders. In aqueous deficiency, mostly the patient has these 3 or 4 complaints. They complain of a severe burning sensation that wakes them up at night. They have to get up to put gels even at the night. And sensitivity to light. Whenever you see them, they will have a squeezing kind of eye motion. This is a lusterless cornea where you can see that the tear film is reduced, and when you stain you see multiple punctate epithelial erosions. This is a case where there are numerous filaments on the cornea in severe aqueous deficiency. So how to treat them? Yes, lubricating eye drops are the initial stay. Viscosity building agent should be used. Lipid containing eye drops are not required. Today, sodium hyaluronate is the preferred choice because it augments the aqueous layer, and extra additions like dextrin and glycerine are important. Osmoprotective agents such as trehalose and erythritol will reduce the hyperosmolar stress. So apart from medical therapy, which includes lubricants, there are other eye drops and systemic tablets that can be used. Rectify the primary pathology. That is, if there is a lid disease or the patient has an autoimmune disease, the systemic treatment should also be started, and then stabilize the surface. So what else can be used? Apart from lubricants, we can use steroids, immunomodulators, mucolytics, and supplements. We will be discussing all these in our future slides. Then you can also use contact lenses, autologous serum, intense pulse light therapy, punctal cautery, amniotic membrane, and the punctal plugs. Now, glucocorticoids, especially prednisolone acetate and loteprednol eye drops, they are anti-inflammatory and they act on all the chemokines, adhesion factors, inflammatory factors. They are an important part of treatment. You can add as a second drug cyclosporin A and tacrolimus. Cyclosporin A I prefer 0.05%, tacrolimus 0.03% topical, and new drug for 5% lifitegrast is also available. Now, the role of mucolytics. N-acetylcysteine, which was first used in pulmonary disease, can be used in aqueous deficiency dry eye. It is available as a mucomix injection. 20% is too strong. Take 4 ml of the CMC and mix it to 2 ml to get a 7% of mucomix injection. We can use autologous serum because tears contain essential components for ocular surface, which is also present in blood. So around 40 ml of blood can be taken and centrifuged and diluted to 20% with saline, and there can be allocated in 5 ml bottles, refrigerator, and used. Next is punctal plugs. This is a more popular abroad than here, but we do see many patients where we can use collagen plugs, hydrogel plugs, or silicone plugs, which are of various types. They go into the lower punctum and they prevent the loss of tears from the lacrimal passage. Now, punctal cautery is a more preferred choice because these cases which are very severe, always do the syringing first before proceeding with the punctal cautery. Remember, this is a permanent procedure. Once you occlude the lower punctum, reversing it by the oculoplasty is a very difficult procedure. So make sure it's really required. You can do both upper and lower punctum in selective cases. Scleral lenses can be used. There is a reservoir of fluid. They reduce evaporation. Make sure there are no synechiae, there is no symblepharon before using this. It also improves vision by correcting the irregular astigmatism. Coming last to the mixed dry eye disease. What if your aqueous deficiency also has an evaporative dry eye, that is your meibomian gland dysfunction? Now, our traditional warm compresses massage may not work. We have something today called intense pulse light therapy, which is selective photothermolysis by using a broad spectrum polychromatic light. This ablates superficial vessels of the eyelids, decreases inflammatory markers, and also aids in collagen remodeling. Now, different devices are available for IPL therapy. The EI platform has something called regulated pulses, where the energy spectrum are precise to stimulate the meibomian glands. They have also been useful in these aqueous deficiency, dry eye, allergy, blepharitis, and in OST due to anti-glaucoma medications. This is a small device where we use it and give shots below the eye in 5 in number on each side, and this is a very easy procedure that can be used in the outpatient department. IPL therapy, apart from the meibomian gland dysfunction and Sjogren's disease, it can be used also for allergic conjunctivitis, blepharoconjunctivitis, and also in pediatric patients. To conclude, any case of aqueous deficiency dry eye disease, first always start with tear supplements, and to that you can add your gels and ointment that stay in the eye for a longer time. In severe cases, which most case it is, add your topical corticosteroids. I might start with prednisolone acetate and then reduce to lotiprane and then finally stop. Do add cyclosporin and tacrolimus. In non-responsive cases, you can use your lacrimal plugs, more importantly punctal cautery or IPL therapy. Use for filaments, you can either remove or use mucolytic agents. And do not forget to be in collaboration with rheumatologists to start oral corticosteroids followed by oral immunosuppressants. And we see most commonly HCQ, methotrexate, and azathioprine being used. And you can use pilocarpine also in order to achieve a complete holistic control of this disease. Thank you very much. Yes, yes, we can use. Rheumatologists do use for quite some time, provided patient doesn't have side effects like excess salivation or excess sweating can also happen with pylo. So initially we give a trial of 1 month where we initially start with once a day and then we increase it to 3 times a day if patient is tolerating. I usually give for 6 months and then stop. Yes, sir. Such patients would mostly fall into the category of evaporative dry eye because they are sitting in front of the system which is causing evaporation of the tears, not aqueous deficiency. So for them, the topical steroids are not indicated. Though they may feel symptomatically, it will be more of a steroid abuse only. So only lubricants and gel works better. Of course, we tell them take frequent breaks and reduce the screen time, reduce the mobile, which they don't do. So the gels will stay in the eye for a longer time, longer retention time. So instead of reserving it for bedtime, we can give once in the morning and once in the evening and add frequent sodium hyaluronate lubricants and avoid steroids for such patients. Topical steroids only for very severe, bad ocular surface with lot of punctate erosions, filaments, and where there's lot of inflammatory responses, which is usually not seen in these kind of patients with a computer vision syndrome. Mm. Although studies reveal different things, what I have seen is most of the patients are comfortable with sodium hyaluronate or HPMC, that is hydroxypropyl methyl cellulose. So these two are currently my drug of choices. But then every patient works differently. Some patient use CMC for many years and they are okay with that. But my first, because the retention time is longer. So first drug of choice for me is sodium hyaluronate and then second would be HPMC. Yes, yes, definitely. Yes, HPMC ointment. Yeah. Thank you, sir. Thank you. Yeah. Yes, there have been studies, but I haven't tried personally. Um, yes, yes, yes. Yes, we can start with a combination of steroids and this anti-inflammatory, and then once we wean off steroids, the anti-inflammatory drugs continue. But that also, I think they give for 3 months or maximum 6 months, including lifitegrast. But if you go for cyclosporin and tacrolimus, that can be given lifelong. Tacrolimus works very well, provided patient tolerates it. Just a small quantity inside the eye before bedtime for all these patients with aqueous deficiency works very well, and lifetime it can be given. Mm. Thank you.
So we go ahead with the next talk, an ophthalmologist view on Sjogren syndrome by Dr. Ritika Malik.
Yeah, thank you, ma'am. So I'll be speaking about Sjogren syndrome, approach to its diagnosis and management. So what do we know about Sjogren syndrome is it is an autoimmune disorder, and it's the immune cells attacking the exocrine glands. So though cases were seen and recognized as some of these in the early and the late 1800s, but it was not named as such. So Henrik Sjogren in 1933 was the first person who did name the disease, and he even came up with a different term, keratoconjunctivitis sicca, for it. So the SS syndrome is also the KCS syndrome. So Sjogren syndrome is far from a rare disorder, and it's approximately one half of the rheumatoid arthritis population is affected, from 0.5% to 1% of the population. Very famous Venus Williams suffers from this disease, and it's often found in middle-aged females. So the time course of autoimmune disease is, although SS was considered as a T cell mediated disease, tissue destruction is associated with the infiltration by the mononuclear inflammatory cells, including not only activated T cells, but also activated autoreactive B cells according to the lesion of severity. So Sjogren syndrome symptoms are dry eyes, dry mouth, glandular swelling, dry throat, dry skin, and dry nose. So extraglandular symptoms are also there, which are recurrent bronchitis. You give a history of wheezing and asthma, abnormal liver functions, joint pain, small joints pains typically, deformity of joints in the severe conditions, digestive problems such as an IBS is sometimes masking the disease, and also neurological problems are prevalent. So we do have differentiation such as primary Sjogren's and secondary Sjogren's. So primary Sjogren's directly affects the exocrine glands, which is known as the Sicca syndrome. And the secondary Sjogren's occurs with the other autoimmune diseases such as SLE, rheumatoid arthritis, scleroderma. So how do we go about the ophthalmic evaluation? First is our Schirmer's test, 1 and 2, ocular surface staining, look for any punctate erosions, the SPK scores are fine SPKs, and the tear film breakup time is also equivocal to the severity of the disease. So this is the Sjogren's International Collaborative Clinical Alliance, which is the SICA cohort, which is approved by the American College of Rheumatology. So it gives us an indication of how do we categorize and grade the staining of our ocular surface. So the staining is also corneal and also the conjunctival. So we can stain it either with fluorescein, lissamine green, and rose bengal also, which is available commonly in your clinical practice. So this has been a study which was done in Narayan Nethralaya. So this shows that the immune cells on the ocular surface of a dry eye disease, which shows a higher activity of the CD4 T cells and also a lower activity of the protective NK T cells. So this research was based on the Schirmer's, which was collecting the tear film, and also the immune assay, which was the immune wash which was collected. So it did show a relation where the OSDI was also matched with the Schirmer's. So a higher OSDI, reduced Schirmer's, and an altered tear film breakup time shows that there's an inflammatory dry eye disease underneath. So when do we investigate? When there's obvious systemic symptoms and signs, low Schirmer's value not improving with lubricants, and higher staining score above the grade of 2. What do we investigate? So first we do the blood investigation, do a simple CBC count, RA factor, C-reactive protein, and the ANA for the SSA, SSB. And the ANA titers, which are higher than 1:160, is mostly directing to the Sjogren syndrome. Anti-Rho SSA or anti-La SSB antibody should also be tested further. So they Rho SSA have a higher diagnostic specificity than the anti-La SSB antibodies. What else can be done is celiometry, which is the measurement of the salivary flow, which is done by the ENT specialist most of the time and also the rheumatologist clinics. And a lip biopsy can be done, which is rarely done, but abnormal labial salivary gland biopsy results have a highest diagnostic specificity for the Sjogren's syndrome. So this is an algorithmic approach for the management of dry eye in general, which I will not go in detail. But what do we do if there is a Sjogren's patient? So we can give mechanical or gustatory stimulation or salivary substitutes for your oral dryness. For your ocular dryness, start them off with the lubricants, add the gel ointments, then start with the cyclosporin 0.05, 0.1 or 0.09%. We also have liftigrast in the market now, so we can add that to the patients if they are not responding to the cyclosporin, and also topical acetylcysteine 10% solution for your filamentary keratitis. So if this is not helping, along with that, we have in conjunction with the systemic therapies, for which I think we should consider according with the rheumatologist. So make friends with a local rheumatologist and do refer your patients there. So oral pilocarpine does work very well. And also in severe cases, punctal plug insertion and autologous serum should be given. Seeing that the autologous serum is prepared in a sterile condition, most of the time it will show a little bit of redness when we use the autologous serum in the early stages, but most of the time they do adapt well if given with a steroid cover. So systemic therapies in association with the rheumatologist is obviously immunosuppressive or immunomodulatory agents, which is commonly methotrexate, leflunomide, and azathioprine also. And you can also start on oral cyclosporin A. The side effects are a little less, but always monitor the LFT KFT of the patients. Some of the biologic agents which are available are rituximab, IFN alpha 3.1 mu 3 times weekly, and also infliximab. So close monitoring of the blood parameters, see the inflammatory factors reducing or increasing, LFT, KFT as I mentioned, and keep a close watch on the fever and other systemic infections occurring in the body. Adjuvant measures also tell them environmental factors which they can alter, quit smoking, improve the sleep hygiene and physical fitness. I'll just run through a little cases. So this was a 55-year-old female, dryness which was complained. She was using lubricants but no improvement since a long time. Schirmer's was 4 mm at 5 minutes. T-BERT was also altered and ocular surface grading was 2. Inflamed ocular surface was there, and ANA titers were positive for SSA and anti-Rho. So we did see that she was a primary Sjogren's Sicca syndrome along with a little bit of MGD. So MGD was treated by our normal warm compress, eye mask, lid hygiene, and doxycycline. Also preservative-free lubricants were given. I generally give unim packs of preservative-free lubricants so that they use it more frequently, and lubricant gel ointment twice a day, and cyclosporin 0.05. I start them off and then step up to 0.09 if required. And oral methotrexate was added 10 milligram per week. So after there was some improvement, but she was not very happy. After 3 months of intensive therapy, she was still complaining. So we did plan her for an intense pulse light therapy. So this is our intense pulse light therapy on the Thermi Plus, which is also improves the aqueous deficiency dry eye also in most of the patient in improvement with the MGD status. So this was her ocular surface analysis. If you can see, it was around 5 and 3.9. It did improve slightly to 6.1 and 6.9, but she was not very happy symptomatically, though quantitatively her results did show improvement. So this was a second case which was showing that abnormally high ESR and CRP levels were positive, and rheumatoid factor was also positive in this patient. So she was a case of secondary Sjogren's with rheumatoid arthritis. And what we started with her was preservative-free lubricants, gel ointments, preservative-free cyclosporin, also a short course of steroids, and removal of the filaments was done. And oral methotrexate was added by the rheumatologist. 1 month post-treatment, she was doing well. So just final summing up is primary Sjogren patients do have an increased relative risk for the development of B-cell non-Hodgkin's lymphoma also. So we have to, along with our ophthalmic evaluation, we have to do a complete systemic evaluation well, and make friends with your rheumatologist, keep referring them your patients, and they will refer you back their dry eye patients also. And from my side, just early intervention with systemic therapies is needed in Sjogren's syndrome. Thank you. Any questions? Thank you.
So the next talk is a definitive permanent surgical treatment, surgical technique to manage dry eye in ocular surface disease in neurotrophic keratitis by Dr. Arun Jain. Dr. Arun is not there. So Dr. Namrata, she is also not there. Dr. Nimrata Dhami. Dr. Nimrata Dhami. No, not there. Dr. Nupur Gupta. Yeah. So the next talk is ocular dysbiosis in limbal stem cell deficiency.
A very warm good afternoon to all. So I would be just touching on the topic of microbial dysbiosis and limbal stem cell deficiency. We all know that limbal stem cell deficiency occurs due to a direct damage or destruction of the niche environment, and it is marked by neovascularization, loss of corneal epithelium and stroma, and the cornea eventually becomes opaque. So coming on to human ocular microbiome, it is unique because it is unlike the gut microbiome and the skin microbiome. It is exposed to the environment, and it is paucibacterial in nature. The three main phyla which are recovered from the ocular surface are Propionibacterium acnes, Corynebacterium, Staph epidermis. Some viruses and fungi also make up the human ocular microbiome. So in limbal stem cell deficiency, you do have two components, a microbial dysbiosis which happens, and also an inflammatory microenvironment which propagates the disease of limbal stem cell deficiency. So to understand the imbalance in the microbial composition and its diversity, which may be hallmarks of limbal stem cell deficiency, which may lead to poor wound healing and epithelial cell dysfunction, we undertook a study where we evaluated profiles of ocular surface microbiomes in patients with limbal stem cell deficiency and compared them to healthy controls. So the sample taken was from the inferior conjunctival fornix. DNA was isolated. 16S ribosomal RNA PCR was done, and then these were sequenced to understand the microbial population by bioinformatic analysis. So the the study that was conducted to understand, because it's a novel topic. So what we had, this patient profile were usually patients of chemical injury or Stevens-Johnson syndrome, and when we compared the rarefaction analysis, which gives us this Shannon and the Simpson index, basically it gives us the richness, the amount of bacterial load in the conjunctival flora, and the diversity. So the species richness which we saw in patients of limbal stem cell deficiency was much higher than the control group, and also the diversity was also more. So there were more genera and phyla isolated from patients of limbal stem cell deficiency than we saw in the controls. And when we looked at these are the heat maps that are generated from the microbial flora. So there was a clear and significant difference in the bacterial species composition. The healthy ocular surface is characterized by a low diversity community with few dominant species. In contrast, in limbal stem cell deficiency, you have a marked dysbiosis, meaning there's an increase in the diversity and emergence of new different bacterial profiles. So in the patients that we study, we found a high abundance of species like Fusobacterium, Corynebacterium matrixotae, and which are associated with inflammatory processes elsewhere in the body. And there was a reduction in the core microbiome or the normal commensal community that is present. So that is the reason for disruption of the ocular homeostasis in these patients. So these patterns were then seen in these patients. There's a alteration in the diversity and a shift in microbial abundance in these patients. Because of the microbial imbalance thus created, there is a reduced abundance of beneficial commensal bacteria, which may contribute an increase in the pathogenic taxa, which may contribute to the ocular surface inflammation seen in limbal stem cell deficiency. So the future holds promise for this, because you may have some microbial biomarkers to detect and to treat microbiome targeted therapies for limbal stem cell deficiency. It may help in patient education and awareness on how his disease is progressing or what therapies are having an effect on the microbiome. And research on microbiome based diagnostics and therapies holds significant promise for enhancing patient outcomes and quality of life. Thank you. Yeah. Depends on the stage of the limbal stem cell deficiency. In mild limbal deficiency, you do not need. But suppose you're giving steroids to a patient with limbal stem cell deficiency, you definitely should add a prophylactic antibiotic.
No, but the introduction of antibiotics per se, like would it not destroy the normal microflora of the ocular surface?
So in mild, we do not need to give, but in severe cases or moderate to severe cases, where you're anyways giving steroid, you are disrupting the microbial flora. So there it may be needed. So a targeted approach may be better, and a customized approach may be better for the patient-to-patient variation.
And before any kind of surgical intervention for the ocular surface disease, like you're doing an suppose a limbal stem
Definitely. So prophylactic antibiotic for all such cases who are undergoing surgical intervention should be given.
no, but do you do sort of like conjunctival swab culture before proceeding with the surgery?
Yes,
So
bilateral blind patient with Stevens-Johnson syndrome, which suppose we're doing a comet or any other transplantation, we should do a conjunctival swab.
Okay. Done, Nimrata? Yeah. So the next talk is Reimagine Relief with Cyclosporin by Dr. Nimrata Dhami.
Good morning, everyone. So I'm going to be talking about, the spectrum and the scope of cyclosporin in our day-to-day ophthalmological practice, especially in dry eye and ocular surface. So this is the scope of cyclosporin. It is not just limited to aqueous deficient as the popular thinking goes. We can use it in immune-mediated dry eye, be it blepharokeratoconjunctivitis, neurotrophic keratopathies, even post-adenoviral subepithelial infiltrates, allergic eye disease, and very importantly, in post-LASIK dry eye, its usage has increased a lot. So dry eye in the immune-mediated scenarios, it's very important to treat white inflammation. White inflammation because the eye surface is not red hot, just as the normal understanding of the word inflammation goes. You don't feel or see anything, but the eye still has inflammation going on, although you might feel the eye is quiet and normal, the TBUTs are normal, the Schirmer is normal, still what is going on? Also in meibomian gland dysfunction, most of these, as you know, even in young males, these blepharokeratoconjunctivitis have a lot of autoimmune component, and they have these recurrence of attacks. Staphylococcal hypersensitivity is the other word which we use for this. Are also important indications for using cyclosporin. Also post LASIK dry eye, especially post PRK and post cross-linking in haze regulation, also cyclosporins have a very big role. So dry eye, again, there's an iceberg phenomenon. I always feel it is underreported and undertreated and under-acknowledged as well by us as ophthalmologists. So not going into the details, obviously, we're just, I think, diagnosing or treating only 40%, 60% of the patients are still, underdiagnosed and undertreated. But the common, theory is just don't think, go give the lubricating drops. These, patients, if I might say, are actually the most nagging and irritating patients in your OPD, but they are actually the ones which are neglected. And if you own up this population of patients, you may actually be increasing your practice just by being the good doctor here. So whatever the cause, we are going to give the same lubricant. This is not what I try to advocate here. Going back to where it all began, the classification of dry eye, aqueous deficient, evaporative, a very boring slide, but I want you to ponder over one thing. Is this root cause based or is it just effect based classification? We are not talking about the root cause. Aqueous deficient is not the root cause. This is what has happened. It is an effect based classification. So if we want to start our treatment based on if it is an aqueous deficient or an evaporative dry eye, I think that's not really the sole purpose over here. We need to understand what led to the aqueous deficient, what led to the evaporative dry eye component. So I think writing lubricants nowadays, it's like standing on this signal. It's a jargon. You don't know what to prescribe when. So pouring these drops alone will not help. So the food for thought is that not all dry eye is same. You cannot treat a dry eye with due to rheumatoid arthritis the same as that with MGD. So it's important not to treat the root cause and not just the effect. So artificial tears, they mimic natural tears and they are the first line of treatment, but we need to understand that we need to escalate the treatment if there is severe inflammation, underlying systemic disease. If you know the patient has some autoimmune disease going on, GVHD, or there is rheumatoid arthritis or thyroid, you need to understand this dry eye is going to trouble you a bit more and needs more attention. Meibomian gland dysfunction, gadget usage, or unhealthy lids and glands, again you need to undertake those things more. Anatomical disturbances, and again neuropathic ocular pain, it's a very important new entity that has been included in the DUCE 2 classification. Neuropathic pain, which I like to explain as pain without stain. That means you're not seeing anything but the patient is complaining of pain. So inflammation, hyperosmolarity, and inflammation lie at the heart of dry eye disease. This is what I want you to get from this. So cyclosporin, what it does is that in its own way, it is going to stop the cascade, work at the ICAM receptors, and it is going to stop the cascade of tear, the inflammation, and hence lead to slowly increase to goblet cell density and increase the tear production. Because when the surface is not under stress, the tear quality and quantity both improve. Hence, not only aqueous deficient, even evaporative dry eye has become an important indication for prescribing cyclosporin. So the action, just to bore you a little with the place where it works, inhibits T cell activation, enhances goblet cell density, reduces inflammatory cytokines, and reduces the expression of all the inflammatory receptors so that the eye surface gets stable. So it increases tear production. I think we've covered this. So all the factors, where you feel that the dry eye is just not going to be limited to lubricants is very important, that you need to look beyond and you need to treat beyond just what you see, in terms of giving them lubricants. So again, these are the various components, glycerine and all these are osmoprotectants. Castor oil, it is a common activator which helps the better penetration of these drugs, cyclosporin, and so many other complexes that you find in your lubricant. So your lubricant basically consists of all your active medications. They have a viscosity agent, a medical agent, one buffering agent. So all of these have the specific role and toxicity or not to play. So fast onset of improvement as you give these uniform formulations, especially Restas is which is I call the parent drug, and the first on which most of the researches have been done. I think everything else has been just adapted from that. So they all have a faster onset of action. Uniform formulations always helps. As the ocular surface improves, your tears are looking better. Your as the surface gets improved lubrication, the higher order abrasions reduce on the surface, and the visual function also improves. So again, if you prescribe these along with your lubricants, the patient is actually going to come back happier. Tear film stability, as exactly I said, that evaporative dry eye, it has a very good role, and also increasing the goblet cell density. Although these are very small components and we don't talk about them, but they are very important, playing a local functional role in dry eye management. So cyclosporin A 0.05%, and as compared to we have now 0.09%, 0.1% coming up. So this is an optimized concentration. It reduces your stinging and all the other factors which cause non-compliance towards cyclosporin. So adverse events are low and tolerability is better. So the case reports, again, as we discuss in blepharokeratoconjunctivitis, as you can see, long term you cannot give steroids in these patients. You need to accompany them with the immunomodulators, because these are recurring conditions, chronic conditions, very important conditions in which you need to think and give beyond steroids. Meibomian gland dysfunction also, not just to aqueous deficient, the scope of cyclosporin has increased. Post-LASIK dry eye also, because we are advocating our post-LASIKs and the outcomes of post-LASIK, like we want our patients to have an instant recovery. We're actually advertising them like a Maggi noodle formulation. We want the patient, both the doctor and patient want instant gratification. So you need to accompany these drugs along with your lubricants. Again, during the early postoperative period with SMILE or LASIK, either ways, although the cut size is small, but still the dry eye does happen. Evaporative dry eye, yet again, you can accompany it with your initial hot fomentations and ointments and expression of glands. These drugs start helping. Post-adenoviral subepithelial infiltrates, I think this is a very under-documented, but this is, I think, a very common indication to give cyclosporin. and for long term, because these are chronic patients who keep coming back to you and are really, really tough to treat. Again, primary and secondary Sjogren's syndrome, the classic indications. Neurotrophic keratopathy also, they have a very good role, especially preservative-free unum formulation is the way to go in such cases. And again, allergic eye disease, very critical for you. I feel we see so many, young lads, they lose their vision because of not just allergy itself, but over prescription, and everybody wants to give them a steroid. Nobody thinks of, putting them along with some immunomodulator for long-term therapy. So very, very important condition, because if we don't want the eye to go into rubbing and keratoconus, we don't want them to lose to steroid-induced glaucoma itself. Again, post cataract surgery dry eye, as we increase the premium IOLs, we need to take care of the ocular surface, because I think the patient does have dry eye and a cataract, but they think that, just getting a cataract surgery with a premium IOL will solve the dry eye itself. So, nowadays with the demand in cataract surgery also increasing, like LASIK, and the outcomes expected to be as high, patients want a LASIK type of outcome for their cataract. So dry eye and ocular surface needs to be really taken care of. And again, anti-glaucoma medications, anything which disturb the surface needs something more than your lubricants or even mild steroids for a short course. So cyclosporin 0.05% elevates the dry eye symptoms at all severity levels. Thank you so much. Yeah, so this is the most common question that I get, especially like, in children, people ask me, how long are you using it? I interestingly asked this question from LVPI faculty when I started my practice, and they said that they've been using for 10 years also. So when I was taught, they said that, you don't use it for that long, but you can give it till the time you feel, that especially in kids that now, when they phase out of their puberty and their allergies, you feel that the surface is not stable, you can give it for 10 years or a very long time, especially like in Sjogren, you have to give it. You have to understand what your hydroxychloroquine is for the body, your cyclosporin is for the eye. You need to combat the local immunity, so you can give it for a very long time without a problem.
How do you deal with that? How do
Yeah,
you
so
counsel them?
burning sensation, right now, if you go with the ones which are the multi-dose vials, if they have preservative, burning sensation and loss to compliance is very high. So you have to really tell the patient, please don't change the doctor, I will change the medicine, because they will go to someone else, and then again they will keep running around, because this understanding of giving cyclosporin, the heart to give cyclosporin is only limited to people who do very religiously ocular surface or cornea, right? So you have to tell them that you're going to change the drug. You have to be very patient. Burning sensation is common. It is more common with tacrolimus, because that is in ointment form. Nowadays, with the unum formulations, I very hardly had a patient. I never start with lubricant, I start cyclosporin. I always kick it with steroids. 3 weeks, once I know the steroids are weaning off, the cyclosporin is going to take over. Never give it just with on an inflamed surface. Give your steroids, your lubricants, gels, and a cyclosporin. Let it be, the one-man show later on after 3 weeks to 1 month, not at a first instant. If you prescribe it with good counseling, if you prescribe it with taking care of the other components, the loss to compliance and burning sensation is very low, especially nowadays the unims are coming very good. So that is there.
Ma'am, any experience with liftographs now? Will you be switching
Yeah.
to?
So I tried it in a few patients.
Yeah.
I was a very religious cyclosporin provider. Still I am. I tried it in a few patients, and they I think market on the fact, or they bank on the fact that it is a faster onset of action and less side effects. In those 2-3 patients, they have been happy so far. The ocular surface also looks stable. But I'm still reserved about it, and my heart and soul goes in giving cyclosporin. 1 or 2 patients I've given, frankly not given much. But again, the preservative-free ones, the unims are very costly still. And the multi-dose vial again have that issue of a bit of a burning sensation.
Yeah, that's what the patient came back
Yeah,
with. So,
So Ajanta has one, which
One,
is multi-dose, but it was fine. Ocular surface looked okay, but the patient complained of burning. Yeah, so that was there. So I was like, still my heart is into
same with
cyclosporin. Sure.
Thank you.
Yeah. Don't go by what the company says. They advise a lot of things. We have to see our patient. I always tell, we don't treat the reports. We don't treat, what the company tells us, we treat the patients. Don't look at anything, see what you tailor and customize the treatment for yourself.
Because as you said, cyclosporin we can continue for many years.
Yeah, yeah.
Some patients we
you
have
have to
continued
see to
lifelong.
understand. I tell this is my standard line. What your HCQ is for the body, your
Right.
cyclosporin is for the eye. There is you need to combat the immunity over there.
So that 3 months dose for lifitegrast doesn't make sense.
No, I
because
never
it's-
listen to this part. When they're telling me the dose, I tell them that's my job. All right. Thank you so much. Thank you. Thank you.
So the next talk is by Dr. Namrata Sharma, the role of intraoperative prophylactic amoxicillin in prevention of endophthalmitis.
So I would be talking to you about role of intracameral moxifloxacin in prevention of post-cataract surgery and ophthalmitis, and particularly about the randomized controlled study that we have done on 60,000 patients. There are no financial or proprietary interests, and it has been decreasing over the last decade from 1 to 0.05 to 0.1%. And of course, prophylaxis is important preoperatively with topical antibiotics, povidone iodine installation in conjunctival sac for 5 minutes, which I think is the most important tool that we have today. Intraoperatively, intracameral antibiotics, and postoperatively also the topical antibiotics have to continue. In the recent studies, it has been shown that in India, gram-negative infections and fungal infections are more important as compared to coagulase-negative staph, which occurs more globally, but staph, both coagulase negative and staph aureus, are the commonest organisms for which measures have to be taken. In 2021, AIOCMTC4 endophthalmitis prophylaxis survey, 66% respondents, they said that they use intracameral antibiotics, and 80% believe that commercially approved intracameral antibiotic is important, and if reasonably priced, this would increase adoption of intracameral prophylaxis to 93%. These are the 4 drugs which can be given intracamerally. Each has its plus and minus. With moxifloxacin, the advantage is that the preparations are available commercially. There's wide spectrum of action, and it works on concentration-dependent killing. The very first trial was done for intracameral antibiotics was by ESCRS, and they clearly showed that there was 5 times reduction in endophthalmitis after looking at 16,000 plus patients, and advocated the role of cefuroxime. But cefuroxime to make was difficult because it has to be compounded in pharmacy, and also because of the emergence of the resistant gram-negative isolates. Vancomycin has also been tried intracamerally, but there's a risk of hemorrhagic occlusive retinal vasculitis, and so that is why people have given up its use. And intracameral moxifloxacin, preservative-free, is the one we are looking at, is given 500 microgram per 0.1 ml. If you look at the efficacy in 1 lakh plus patients, a retrospective study by Arvind Eye Hospital did show that there's 4 times increase in the patients undergoing SICS. And likewise, 6 lakh plus patients, they did show again that it decreases the rate of endophthalmitis 3.5 times. Whenever you have a PSCR, the chances of endophthalmitis rate increases, and in their study it was by 7 times, and again moxifloxacin helps to decrease it to 0.21% in cases where PCR is there. It is quite safe because there are no adverse events reported on visual acuity, IOP, endothelial cell loss, pachymetry, or AC reaction. And this was the first survey that we did in 2017, which concluded and which highlighted the fact that there were people who were using subconj antibiotics in our part of the in the various parts of the country, as opposed to the ASCRS survey where they did not use any subconj antibiotics. And also moxifloxacin was being used more in the ASCRS survey as compared to the AIO survey. This is the only randomized control trial but does not meet the statistical significance because the power of the study is low in 3000 plus eyes, which again did show that endophthalmitis decreases after intracameral moxifloxacin. This was the second survey we did, and again we found that from 40% in 2017, people have increased using it to 58% in 2022. So most of the existing studies are retrospective and non-randomized, and so we wanted to see in a randomized control study with good power of the study, what is the role of intracameral moxifloxacin. So the total sample size was 60,000 and 30,000 were recruited in each of the groups from 3 tertiary eye care centers, including Sadhguru and Tirupati Eye Center. And ethical approval was obtained. The phacoemulsification was done. The various parameters were evaluated. In 30,000 eyes, intracameral moxifloxacin was used, and in other 30,000 eyes, moxifloxacin was not used. Phaco was done alone. Post-op regime remained the same in both the groups. Whenever endophthalmitis occurred, protocols were followed, which are standard. And in terms of the mean age, gender, visual acuity, IOP, endothelial cell density, central corneal thickness, both the groups were well matched and there was no difference. Also in terms of the incision size, type, location, IOL, optic, haptic size, position, wound closure, as well as the posterior capsular rupture, whether absent or present, both the groups were well matched. We did find that 6 cases in the group where phacoemulsification with intracameral moxifloxacin was given, and 16 cases in which it was not given had endophthalmitis. So the odds of having endophthalmitis was 2.5 times as compared to the control group. As far as the microbiology was concerned, 2 cases in the intracameral moxifloxacin and 6 in phaco alone were culture positive, and also there was resistance to moxifloxacin in 2 out of 7 cases within the phaco alone group. Now, as far as the visual acuity, IOP, endothelial cell loss, central corneal thickness, central macular thickness was concerned, in both the groups it was well matched, which means that intracameral moxifloxacin was safe in terms of these parameters. So this study was done using Moxicip from CIPLA, and we are thankful to them for providing this. And having talked about moxifloxacin, the ASCRS advisory is important because it clearly says that you have to use the correct concentration and the correct dose. Otherwise, there may be a problem of TAS. 0.1% is not available in India, 0.5% is only available, and we recommend 0.1 ml of this. 0.1% is available in US, and 0.1% if you use in increased concentration, then that can cause to TAS, as anecdotal reports have been reported. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery, but of course you do have to give pre-op and post-op topical antibiotics. Thank you very much for your kind attention. We don't make point. We don't use 0.1%. We are using only from. No. Thank you.
Ma'am, you can go ahead with your next talk also, like
The
talk on
next, no, it's not here.
Okay.
It's changed actually. They must have given you the old.
Okay. So the next talk is on the role of biopsy and cicatricial disorders of the conjunctiva by Dr. Jitender. Yeah. Dr. Santosh sir. Salvaging the unsalvageable, management of advanced ocular surface disorders.
Good afternoon. Thank you for letting me infiltrate the cornea session. I'll be speaking about ocular surface tumors, salvaging the unsalvageable. If you look at the literature, you'll be surprised to see that about 25 to 40% of ocular surface tumors actually recur. That's the data that is available. and each recurrence, especially melanoma and squamous cell carcinoma, adds to the metastatic potential. Otherwise, the risk of metastasis is less than 1%, and whenever it recurs, obviously the risk of metastasis increases. There's always a concern of vision salvage and eye salvage whenever a tumor recurs, and you tend to very quickly do either extended enucleation or orbital excitation in the fear that the tumor may again recur. But then there are very simple oncological principles which can help you reduce the low rate of local tumor recurrence and also salvage these eyes. One main oncological principle is base clearance at the time of surgery. When you excise the tumor base has to be absolutely clear of residual tumor cells. And if at all the base is positive, you have to provide histopathology guided adjuvant therapy. Now, edge determination is very easy. It is actually upfront. Whenever you look at the tumor, what is seen is this, but beyond that, there is thickened conjunctiva that often stains, that is that. And beyond that, you go about 4 millimeter clinically clear margin. So your edge clearance is pretty easy. On the corneal side, use absolute alcohol to do corneal keratoepitheliectomy. So even here, the edge clearance is fairly achievable. But the base is opaque to you. You cannot see how deep the tumor is. In a small tumor, it is easy to estimate the base. There are indirect indicators such as moving the tumor on the epibulbar surface using a wet cotton tip applicator is one. But then sometimes, like in this patient where there is corneal OSSN, there is no clinical evidence at all that the tumor was full thickness stromal. But on UBM, you can see that there is increased internal reflectivity in this part of stroma, and that stroma is splayed, whereas this is the normal stroma. So obviously stroma is infiltrated. So clinically, you are not able to tell that, right? But the good news is that OCT and UBM correlate with histopathology. So here is an example where what you see is the tumor on OCT and what is seen on histopathology. You can see this bubbly T-lens here, which has already been taken out, and our dissection is always at the episcleral plane. So you can see nice correlation. So you can actually use histopathology and OCT to guide your treatment to reduce local tumor recurrence. So when you excise the tumor with edge and base clearance, the results are absolutely good. But what if the tumor has already infiltrated the sclera or the base is positive on histopathology? In such patients earlier, 5, 7, 10 years ago, we were doing either extended enucleation or orbital excitation. But it is said that not all people with ropes around their necks don't always hang, and we have all these measures to take care of them: plaque brachytherapy, stereotactic radiation, chemotherapy, chemoradiation, and targeted therapy. Starting with plaque brachytherapy, we use ruthenium, which is a ready-made plaque. So we simply have to customize the dose to the patient. Primary plaque brachytherapy is when you do it without having to do a complete tumor excision. Like this patient who has a corneal stromal melt, but he is not keen on enucleation at all. So here, if you try to excise this tumor, there will be a gaping hole at the limbus which you can't easily repair. So we would, if at all you'd need histopath evidence, you would simply biopsy from the safe zone and apply plaque right on top of the tumor. Or when there is preoperative imaging evidence like this, that the scleral base is breached, then again you already know that the tumor is infiltrating the sclera. There you do plaque brachytherapy. Dosage calculation is very simple. We measure the height of the tumor, add 1 millimeter, and then calculate the dose by using this software. Now I'll skip the surgery because of lack of time. This is how the primary plaque brachytherapy looks. 3D conformal dosimetry was performed on this tumor, and the plaque was applied right on top of the tumor. There is good stromal recovery and there is no melt at all. You can see tectonically normal sclera. One more patient where primary plaque brachytherapy was performed. This is a patient where there is diffuse conjunctival melanoma, multiple prior excision, thin sclera as you see here, multifocal melanoma, you see this, and also he has ciliary body involvement as you can make out from the UBM. But he has 6 and 6 vision and he's very keen to have the eye salvage. Here we did the same procedure again. We mark the perimeter of the tumor, excise it using RF radiofrequency electrosurgical devices, even excise the muscle that is involved, the length of which we already know by using an MRI scan. Excise the tumor in flush with the scleral base, not to do further lamellar sclerectomy. Then excise all these pigmented areas of the conjunctiva, which is PAM, reinsert the muscle back, and then apply ruthenium plaque brachytherapy after marking the area of application. So this is the area that has been treated. Now we rotate the plaque to cover the rest of the area after the exposure time is over for this particular area. So simply clean up and rotate the plaque to a different area, and finally do excision edge cryotherapy, excision base cryotherapy if you should, and reconstruct the ocular surface with an amniotic membrane and put in a symblepharon ring for a few weeks. So this is how the patient would look after 6 months to a year thereafter without any trace of recurrence. Of course, 90% is the success rate. 10% patients still do recur, for which we have to do other procedures. This was a patient again where we already know that this scleral base is involved, so there is no reason for us to wait to do brachytherapy. We would do primary brachytherapy in this with good success. Secondary is when either the patient is not ready for plaque brachytherapy primarily, or you're not sure whether the base is involved or not by the available means of imaging. So here you wait for the pathologist to confirm that the scleral base is actually involved, and then do plaque brachytherapy 3 weeks later after the ocular surface is stabilized. And these are the kind of results that you get. This patient is 6 years post-op. One more patient with secondary plaque brachytherapy. Similar results. And we have about 90% success in eye and vision salvage with this procedure. Complications, of course, are there. Limbal stem cell deficiency. Now we combat that with using primary simple limbal epithelial transplantation when we fear that there could be a possibility of limbal stem cell deficiency, and the results of this technique have been published. Stereotactic radiation can be used in young patients. This was a patient where there was intraocular extension of squamous cell carcinoma with multiple prior excision cells, where he had obviously he was not ready for any kind of destructive surgery. So we used stereotactic radiation, chemoradiation. Here, this is the kind of retinal detachment that he had, and that is the intrascleral extension. That's on MRI. You can see the extraocular and the intraocular component both seen here. This was clearly exenterable, but still, since the patient was not keen at all and had no metastasis, we used stereotactic radiation. You can see complete resolution of extraocular retinal detachment, the intraocular component on B scan and UBM, and the patient continues to retain his vision. About targeted therapy for patients who have diffuse OSSN, clearly exenterable, both the palpebral conjunctiva as well as the bulbar conjunctiva being involved. We can use injection interferon, 3 million international units, 3 to 6 injections followed by topical therapy and sometimes surgery. HIV positive patient, entire ocular surface being involved with OSS and treated with injection interferon. For lymphoma, which is extended beyond the confines of the conjunctiva, sliver of it hugging the equator and going beyond, obviously not excisable by surgery. Earlier we would give radiation. Now we simply inject perilesional rituximab with good results. Cemiplimab is something that has come in. For squamous cell carcinoma, you can actually chemoreduce using cemiplimab. You can see that this extensive tumor has been reduced to this size. This is from the Shields group. This drug is currently available in India for with specific drug licensing, but is very expensive. So in conclusion, I would say that salvaging the unsalvageable is possible in ocular surface tumors. Careful clinical evaluation complemented by appropriate imaging, risk stratification, combination of therapeutic intervention which you specifically triage to a given patient and customize your treatment, but you always follow the relevant oncological principles. With all these combined, we can avoid enucleation and perhaps extended enucleation and save their eye and as well as vision in these difficult situations. Thank you so much.
The injections are given under the lesions or it is around the lesion?
Which one?
The injections.
Injections are given perilesional.
Perilesional.
Because lesion itself is adherent to sclera, it cannot be lifted up. So if it is only conjunctival, you give intralesional, subconjunctival basically.
So if we have very early OSSN and only conjunctival involvement, so do you go for interferon or mitomycin C?
Mitomycin is currently not favored. We go for either interferon or 5-fluorouracil.
Yeah. And interferon for how many weeks, sir?
Interferon until the tumor completely disappears clinically and on some guided by OCT. And beyond that, we go for 6 more weeks.
Yeah. Okay, sir. Thank you. I think we'll conclude the session here. Can we invite the speakers for a quick photograph, please?